So good morning. I'd like to welcome everyone to the first webinar for the project Working with Children and Youth with Complex Mental Health Needs, an Integrated Training Project. Today's webinar is the first webinar in a 9-part series and serves as an introduction to the project and some key subject areas, including an introduction to the term complex mental health needs and an introduction to systems transformation in the child and youth mental health sector in Ontario. My name is Renee Ferguson, and I'm going to be the moderator for today's webinar. So before we begin, I have a few housekeeping items for your attention. First, question period will be in the last 10 to 15 minutes of this webinar, so we ask that you hold your questions until the end. You'll see a box come up on your screen, and then you can type in your questions. Second, if you happen to be having technical difficulties, we have Meredith Kushner here who's live on email who can answer your questions and help you through those difficulties. You just need to send her an email, and the address is mkushner@ontario.cmha.ca. And then third, there is an evaluation survey to be completed at the end of the webinar. Participants are going to receive a survey and an email. We'll send it to you, and we encourage you to participate. We really want to hear your feedback. So, what do we want to accomplish today? At the conclusion of this webinar, we want to accomplish 3 things. First, we want to have given you some context to this project and information on the upcoming trainings that are available through the project. Second, we want to have discussed a common definition for what complex mental health needs are for children and youth specifically, and then we want this definition to be the one that we use throughout the project. And third, we want to share some basic information on the systems transformation that's taking place in the child and youth mental health sector in Ontario. So for today's webinar, we're actually really lucky to have with us 2 very solid presenters who have lots of experience in the sector. I want to introduce Dr. George Lodenque from the Dr. Greg Lodenque from George Hall Center for Children and Families. He's going to be speaking to us about more in depth about children and youth with complex mental health needs, as well as offer us some context to the mental health needs of children and youth in Ontario. And I should say that Dr. Lodenque is the psychiatrist-in-chief and clinical director at George Hall. Second, from Children's Mental Health Ontario, we have Roberta Bastard, who's the acting director of government and community relations at CMHA. She will speak to us about the systems transformation that's taking place in the sector. So welcome to you both. And sorry, Dr. Lodenque, for that. And of course, we want to give you a chance to introduce yourselves as well. So we have this poll I'd like you to participate in. It's a chance for you to say what field you're from, and so we can get a sense of who's here today. So I'll post this. So we have so far, okay, we're looking at higher numbers in youth justice, child and youth sector. Okay. So it looks like most of the people are coming from child and youth sector directly, and youth justice, healthcare. Okay, good. And not so many from the government and settlement. So welcome, everyone. Thanks for being here today. Okay, so thanks for sharing that information with us. We're here today, as I was saying, for the first part of the training for working with children and youth with complex mental health needs. This is a project that's designed to offer some foundation training to direct service providers in Ontario working with children and youth with mental health needs, and with a focus on children and youth with complex mental health needs. There are 4 pieces to this project, including a live inventory comprising of training that's already available in Ontario, housed on the project website, which is www.complexneeds.ca, and I'll talk about this a little bit more in a couple of minutes. Second, a series of webinars, for which this is the first one. Third, a 2-day face-to-face training that will occur in 4 areas across the province. And fourth, a 6-part online course that focuses on brief services, and I'll come back to this in a little bit. But I'd like to bring to your attention some keywords that would describe this project. The first is excitement. We get the sense that the direct service providers are excited about their work and they want to be able to grow, and it's exciting to be able to witness this and be part of this. Definitely in the sector, there's an examination of the needs that children and youth living with complex mental health needs have, and then how do you service that. And then the other piece that I really want to point out is the collaborative piece. This is a collaborative project. The trainings are not new, but we've worked together with a number of organizations to bring together things that are already available in the province and bringing it under one hub. So how did we get here? How did this project come to exist? Well, in November 2012, the Government of Ontario released Moving on Mental Health. It's an action plan that the government pitched designed to strengthen the services that are available to children and youth in Ontario. And Roberta will be speaking about this later on in the presentation. Through this training project, the Canadian Mental Health Association of Ontario and the Government of Ontario is bringing together training that supports the goals of Moving on Mental Health. So again, I really want to emphasize that this is bringing together, that this is collaborative, and that we're bringing this together under one hub. The training is already out there. We're just making it visible and accessible. So a reminder of what some of the goals are for the Moving on Mental Health: improving access to high-quality mental health and addiction services, strengthening direct service capacity, creating a responsive and integrated system, building awareness and capacity about mental health issues within communities. So what's happening now? What's happening in the sector? Well, I'm sure based on your own experiences in direct service provision, you already know that parents are reporting that finding the right kind of support is challenging. It doesn't mean that the right kind of support is not out there, but navigating the system can be challenging. And teachers, family doctors, and supports are also finding that this current system can be confusing when it comes to navigating. So when it comes to actually accessing the right supports, it can be confusing. At the same time, we know that professional development is very important in terms of supporting both service providers and supporting the navigation of the system. We know that professional development improves services, service quality for service users. We know that professional development affects the survival of providers in the field. We know that professional development benefits individual service providers, and we know that professional development benefits the service and the sector overall. So this project is really about building capacity, right? So building capacity of direct service providers who serve children and youth with complex mental health needs, and it's about strengthening a system. So how will this happen? I mentioned the 4 parts of the project a few minutes ago. So first, we have the inventory of training, so bringing together currently over 60 resources across Ontario on the website. The website is www.complexneeds.ca. The exciting thing about this inventory is it's living, so that if there are things that people would like to see, trainings that people would like to see included on the inventory, they can just add it up directly on the website. Second, there are the 9 webinars on a variety of subjects showcasing targeted interventions for children and youth with complex mental health needs from a variety of organizations. And they cover areas such as youth justice, mental health and addictions, and gender-independent children. So I encourage you to take a look at the website. face-to-face regional training, so counseling techniques using trauma-informed lens. These are 2-day face-to-face regional trainings that are happening across the province, Thunder Bay, Ottawa, Toronto, and London. And then the online course, which is available as of January 2015. It's Foundations course in brief services, and again, it's focusing on children and youth with mental health needs, complex mental health needs, and how to provide brief services to this particular population. So I've mentioned a few times this word, complex mental health needs. What is it exactly? Dr. Lodenkwe will be speaking about this a bit more, but first I want to look at the numbers before we start to speak about this. So research suggests that between 15 and 25% of children and youth in the province of Ontario would meet the official criteria for a mental illness. This research also shows that the same children and youth who would meet these criteria are only 1 in 6 of these children and youth are actually accessing the services. The situation actually becomes more alarming when you think about the additional challenges that this particular population might face. For example, social exclusion, involvement with the justice system, living with 1 or 2 disorders or multiple diagnoses. These are children and youth with complex mental health needs. So this is who we're talking about when we are referring to complex mental health needs. And so what does this feel like? For people providing services, it can be a lot of pressure, whether it's internal or external pressure to feel like you have to have all of the answers. This can be overwhelming. It can be exhausting. And I think people who are providing services for this reason are very motivated to find support. For children and youth, it can often be frustrating, confusing, and exhausting as well. And children and youth will also look for ways to find attention and get support. And this can be sometimes helpful, and this can be sometimes challenging. For families and supports, again, frustrating. We talked about finding ways to navigate the system can be difficult, can be confusing, it can be exhausting. And again, families and supports are motivated to find support. So the key thing to remember is that people are interested in building their capacity and interested in finding ways to get support and to give support. So this project supports this. It supports the quest for support. It supports the MCYS commitment to strengthening the mental health system, delivering what children and youth need when they need it and as close to home as possible. So just quickly looking at the definitions before I hand it off to Greg and Roberta. For this project, youth refers to individuals up to age 29, and complex mental health needs refers to the following, just as I discussed a few minutes ago. So it refers to children and youth who are experiencing significant, multiple, rare, or persistent mental health challenges that impact their functioning in most areas, such as in the home, in the school, and in the community. So they're trying to navigate all of these systems. So examples of this would be, and it's not limited to, children and youth who are living with co-occurring disorders, multiple diagnoses, children and youth who are living with disorders that are impacted by social exclusion, involvement with the justice system, and histories of trauma. So again, you can find more information about the trainings that are coming up starting today, and you can visit the website at www.complexneeds.ca. And if you have questions, there's a contact number and email in the website you can contact, and we will get back to you. So I'd like to hand things off and welcome Greg Lodenkwe.
Thanks so much, Renee. It's a pleasure to be here, and thanks so much for inviting both Roberta and myself. I'm the psychiatrist-in-chief and clinical director at the George Health Center, which is a children's mental health center in West Toronto, and we are an MCYS-funded agency. So as you noted at the beginning, it is an exciting time in the sector. There are lots of changes, and just really exciting to be a part of. So thanks again for inviting me to participate. So think that when we're talking about mental health is something where there are many different elements that go into mental health or a state of well-being. Most people would agree that moods, thoughts, and feelings are part of mental health. Functioning and productivity in the settings in which kids and youth are typically at, school, home, and work. I think we often forget about physical health, and physical health is intrinsically related to mental health. So we need to be aware that physical health and mental health are related, as well as their social relationships to important people in their life, and then the larger community. So mental health is everybody's business, and in terms of more statistics, just to give people a sense, again, 13 to 22% of children or youth would have at least one diagnosable psychiatric disorder, and more than 75% of adults with mental illness had an onset of their illness before the age of 25. As noted earlier, it's only 1 in 6 with mental health difficulties that actually get a service or get assistance. And really, services don't often work for people, and that's what we've heard a lot of in the last few years. While we're talking about mental health and mental illness, I think it's also important to talk about the flip side, which is protective or resiliency factors, because not every kid who's experiencing a stressful life event or a traumatic situation, not every kid goes on to have a mental health difficulty or disorder. And why is that? Well, resiliency is the ability to cope in the face of adversity. And these resiliency or protective factors encourage mental health and protect against the development of a mental illness. And really, many studies have shown that a secure attachment to a nurturing adult caregiver is the most powerful resiliency factor of all. And I think it's worth just kind of reinforcing that it is a very important protective factor to have a nurturing adult involved in the child's life or the youth's life. So when we talk about a kid or a family looking for service or looking for support, from our point of view at the Children's Mental Health Center, the family usually presents looking for help with a specific or identified problem. Could be a couple of problems, could be many problems, but the family usually presents saying, I want some help with Johnny's behavior. I want some help with Sarah's school difficulties. We're having troubles at home. We're having troubles communicating. So they come with their own identified presenting issue or problem. And then over the course of engaging in services, the therapist or the clinician or the person working with the family might identify other problems or issues which previously were not maybe recognized. So it's sort of a bilateral process at the beginning. So for children's mental health, the most common presenting, and these aren't rank ordered, the most common presenting problems would be behavior difficulties, aggression in the home or the school setting, anxiety, worry, difficulties attending school because of anxiety, learning difficulties or learning disabilities which affect the kid's ability to function at school and may lead to some behavior problems or oppositional behaviors at the school. And then relationship problems. Relationship difficulties are normal. They're a part of human existence. And sometimes relational difficulties get in the way of parent-child relationships. Sometimes they interfere between the kid and their peers. And sometimes difficulties between the parents, marital difficulties, also lead to problems or challenges with the kid. Depression is quite common. self-harm, suicidal ideation are very common presenting issues. And then child abuse or child maltreatment and the sequelae of that. So I think in terms of a broad understanding of complex mental health, which is the sort of topic of today, is not surprisingly, it involves more than one presenting problem. So more than one presenting issue is identified by the family and the service provider right at the beginning of the beginning of treatment. It's complex because it's difficult to address all presenting issues at the same time, and it does require a bit of prioritization, which I'll return to in a little bit. The other thing about complex mental health or complex cases is that it usually involves more than one sector, more than one agency, more than one service provider is involved: health, education, so that would be the school, children's mental health, providing the treatment end, and then any legal or judicial involvement. So it's complicated getting all of those people to give their view of the kid or give their view of the family, and how to integrate that into a cohesive plan going forward. As I said, in children's mental health, presenting issues would be prioritized, and then probably the number one priority issue would be, is the kid safe? Is the kid at risk? Is the parent safe? Is the parent at risk? And that would be kind of the main thing to sort out right at the beginning. So as I mentioned earlier, complex cases require a lot of coordination and communication between all of the people involved in the child's care or the youth's care and the various sectors. While it's important on the treatment end to make sure that we're not duplicating service or that we're not trying to reinvent the wheel, we've definitely heard that that is very frustrating, and it's a slow process for families, particularly if they're in the midst of a crisis or there's some urgency. And it's often frustrating for the service providers as well, trying to get everybody on the same page and trying to coordinate all of the various elements of care. Often families have had multiple services in the past, which is leading to the complexity. And it's often initially a bit unclear what's been helpful or what's been tried. So again, in sort of a broad brush stroke, treatment plans could be usually identified or they focus on short-term goals, looking at risk, safety, stability. And it's important to recognize that it's really hard to commence treatment if there's an element of risk or there's an unstable living situation. So we really have to address the short-term risk, safety, and stability before we move on to longer-term treatment goals. In the mid-range or mid-term goal, we'd be in the gathering information stage. We'd be coordinating, we'd be working with the family as to the longer-term treatment goals. And that's where most of us involved in the child or the youth life would come in. At Children's Mental Health, we're the ones offering the evidence-based treatment or treatment of the presenting issues. It could be individual, it could be the whole family, it could be in the form of group, it could be parent support, medication management, and then transition planning from one service to another, from one sector to another, and there's a lot of work that goes into the longer term goals. So just as some examples, in terms of complex mental health, and we'll go into a couple of more specific case examples, but it could be a teenager with a diagnosed mental health concern like social anxiety leading to school refusal, plus failing academics. And that may be the main presenting issue, but one can imagine that if they're not going to school, then they might be isolated from their peers. They might be sad or depressed. That might lead to some hopelessness. It might lead to some conflict with the parents who don't understand why they're not going to school. So one specific mental health concern can often lead to a complicated set of problems. Parents who are separating and they're having a hard time going their separate ways, we can imagine that that would cause some anxiety or depression in the child. The child might be distracted at school. They might have difficulties with peers. They might be irritable. They might be withdrawn. And then, as my final sort of example, it's a teenager with learning problems. So they're really struggling at school. They don't feel like they fit in. Their self-esteem is affected. They're lashing out at home because they feel like their parents don't understand them. And gosh, while they're skipping school, who are they spending time with? They're spending time with other kids who are skipping school, and maybe they're trying a bit of marijuana. So you can see that one thing definitely can lead to another, and it becomes quite complicated and complex. In terms of a more detailed example, I just picked two cases at random just to go into some detail. So if we have a 17-year-old teenage girl who's living with her family, and she comes into children's mental health and reports that, gosh, she's been feeling depressed and sad for about a year, and she's quite isolated, and she feels terrible about herself because she's missed 45 days of school and she's failing, where previously she was an A student and very, very popular and functioning well at school. She's missed 45 days because she's felt sad and couldn't get up enough energy to attend school. And now she's feeling isolated, and it makes it harder for her to go back because she doesn't want to explain to her peers why she's missed so many days of school. She's a bit embarrassed. She finds it really hard to talk about her difficulties. And then the last thing that she wants to do is go to dance class. She just does not have the energy to participate and function, and she just feels like she's failing at that as well. She's more irritable and argumentative at home, which is very surprising for her parents because previously they've had a great relationship. And then the parents are now disagreeing about the best way to support her. One parent wants to be a little bit tougher and set some limits, and then the other parent is really trying to understand what's going on, and they're now having some fights about what the best way is to support her. And 17-year-old teens like to experiment with drugs and alcohol, and there is some concern about her maybe drinking a little bit too much on the weekends and showing up at the house intoxicated on a couple of occasions. So this is all kind of concerning for everyone. So they come into children's mental health, they meet with a clinician or a therapist, and over time they're referred for a psychiatric consultation. They're seen a couple of times by the psychiatrist. She's diagnosed with major depression. They talked about the option of medication. The family was a little bit maybe ambivalent. They wanted to really try other things before getting to that point, which is very reasonable. So I think that the therapy started off with a little bit of individual support with the teen. She was very reluctant to be in meetings with her parents. They did not have a great relationship, so there needed to be some trust established with the therapist. And then over time, the family and the parents were brought into the meetings, and that proved to be very helpful. They really got an opportunity to understand their daughter's struggles with her mood. She was really having difficulties with her energy and her concentration, and it wasn't a motivation thing. She actually felt very bad about herself. She felt like she was letting her parents down. Once her parents understood that, boy, their communication improved, and they were much more empathic and able to help their daughter get back into school and get back into dance class. And when the family stopped needing to come to the center, they reported significant improvement in their communication patterns. Interestingly, not only with just their daughter who was having mood problems, but also with the other children and with each other. So that was such a rewarding thing to have heard about, that the additional benefit of family therapy was improved relationships across the board and an improvement in the young woman's functioning. Who's now off to university, by the way. At the opposite end of the age spectrum, we can imagine a young girl, kind of shy, kind of nervous, kind of anxious, is coming to the Ontario early years, drop in with her mom. At that point, she was quite shy and was really reluctant to talk in a daycare setting or a larger setting. She was clinging to her mom, clinging to her dad. She had a really hard time being away from them. She lives with her family. They had recently come to the country, and without getting into the details, they had experienced a range of traumatic events prior to arriving in Canada. You know, they witnessed some very traumatic things and left the country quite hastily and had to go to a couple of different countries before they were able to arrive in Canada. Understandably, the young girl was anxious about transitioning to full-day kindergarten because she's never been apart from her parents and didn't really want to be separated from them for such a long period. So a large part of the beginning was listening to the family and understanding where they were coming from, helping them in the short term with things like connecting with the school, housing, all sorts of things to increase stability in the short term. And then facilitating some conversations with the school so that they would be prepared to support this young girl, knowing that she would be anxious. How could they help the parents make the transition easily? And then in terms of a therapeutic intervention, referral was organized sometime later for a well-known group program that's offered. It's called Fun Friends. It's a group therapy program, and both the parent and the child attends the group in separate groups. And that was very helpful to help her transition into a full-day school. Initially, it was rocky, but over time, it went really well. So that's a good example, again, of a complicated case that required a lot of different involvement, but ultimately turned out to be a very successful intervention. So possible signs of mental health issues: behavior, aggression, problems functioning, hyperactivity or withdrawal, inattention, distractibility. And then emotions and feelings, which we call the more internalizing symptoms, low self-esteem, irritability, anger, suicidal thoughts. And it's not like a physical illness where it's immediately obvious. It's not like a broken leg. We have to rely on other clues when we're looking at someone presenting with a mental health issue. It's not obvious. We have to look at how they're dressing, their appearance, their verbal, what they're saying, their nonverbal, their behavior. And then we also rely a lot on key informants: teachers, caregivers, nannies, parents, friends. I've gotten many insights from speaking to the baseball coach or the hockey coach who really gets to know the kids really well and do have great insights into the kids' inner world. And the mental health problems can range from obvious to subtle. So from psychiatry and a psychological point of view, the official psychiatric diagnoses in North America would be based on a standardized system. It's called the DSM, It's recently been updated. And essentially the diagnosis in this manual or in the DSM is based on two main components. Symptom clusters, for example, internalizing behaviors like anxiety and mood, and externalizing symptoms, which we can more easily observe, aggression, hyperactivity, impulsivity. Along with symptom clusters, we also need evidence that the symptoms are affecting their functioning or causing distress. So they're affecting their academics or they're affecting their relationships. And some mental illnesses, which I'm sure many of you are familiar with or have heard about: depression, bipolar disorder, social anxiety, OCD, post-traumatic stress disorder, schizophrenia, eating disorders, ADHD, oppositional defiant disorder, conduct disorder. Children's mental health is different from adult mental health in that in adults we focus mainly on the symptoms and the disorders and how they're presenting, whereas with children and youth we have to look at it in a developmental perspective. What is the child's age? How are they presenting relative to another kid their own developmental age? And of course, the presentation is going to depend on their age and their developmental, and when they achieve their milestones, speech, fine motor, gross motor, and their socialization. In terms of complex mental health, I thought I would spend a bit of time looking at some common presenting issues or some common difficulties that lead to complicated presentations if not addressed, or if the family or the kid isn't provided with some support. So many of you will remember that I spent a bit of time talking about protective factors and resilience and how a secure attachment figure or a nurturing parental figure is so protective, particularly in this young age range of birth to 6. And attachment is, we often think of an attachment as the kid attaching to the parent, but really it's a dyadic process. It's a bilateral process in which the infant's behaviors like crying or fussing are designed to elicit reassurance, comfort, or soothing from the caregiver. And then the caregiver, in response, soothes and nourishes the infant. And there's this lovely dance or interplay which happens between infant and parent, which forms the basis of the attachment process. Now, in the case of child maltreatment, by definition, it interferes with the normal attachment process or attachment pattern. And for a parent who is having a difficult time managing with their child maltreatment could take the form of physical, sexual, emotional abuse. And then we often don't think about neglect as a form of abuse. The neglect is actually has a very powerful impact on the development of the child. The short-term impact of maltreatment can be varied. It can lead to anxiety or depression, as one could understand. And it could also lead to rage and aggression as the kid acts out or is angry. Relationships are often impaired as a result of child maltreatment. And then in terms of the long-term sequelae, anxiety, depression, self-harm, substance abuse, and then running away behavior and delinquent behavior are often long-term sequelae. Other presenting problems in this early age range would be developmental concerns, autism, and then more rare but still worthwhile keeping an eye out for are the genetic or acquired disorders. As the kid grows up and now enters school full-time, we can remember from our own experiences growing up that there's much more emphasis on social interaction and the expectation for self-regulation. you're coming in contact more with other authority figures. And the challenge here is that kids who are school refusing or not attending school are at greater risk for other behavioral, academic, and relational difficulties down the road. At this age range, we're commonly identifying learning disabilities, ADHD, anxiety, tic-Tourette. And then as we make the transition to adolescence, and for those of you in the audience who are supporting your teenagers with this transition, it is marked by the shift from parental authority to independence, autonomy, and the formation of personal identity. There's much more emphasis on peer relationships and the peer group for validation and support rather than the parental figures. And this is where serious mental health concerns start to emerge developmentally. We see antisocial behaviors, experimentation with drugs and alcohol, and then the emergence of fairly rare disorders, 1% to 2%, but they do carry a significant burden of illness and require a lot of support for the kid and for the family, which is fairly long-term. And I'm thinking about psychotic disorders like schizophrenia or bipolar disorder. Again, just to throw up some numbers, I'm not sure if people would be surprised at these numbers. 31.9% of kids, 19.6%. These are high numbers. And in adolescence in particular, if you have one disorder, the likelihood that you're going to have a second or a third is quite high. And again, the presentations in adolescence do tend to be more complex. And I have to give my colleague, Dr. Simon Davidson at the Center of Excellence, the credit for some of these slides, and in particular this one. So we've talked about the difficulties that kids present with, and who do they talk to? Well, gosh, if we look at this data, professionals, 1.8%. That was quite a concerning statistic when I first learned of it. 31.9% of boys or males would talk to a friend, but alarmingly, almost half of them will talk to no one. And then family is not, 10%. So gosh, who are these kids talking to? Well, the data would say that boys are talking to no one. And it's not much better for girls. Girls are more likely to talk to peers, but 31% talk to no one. And we're still not doing a great job at engaging those kids, 1.8% seeking professional support. So we talked about some of the challenges, but specifically, the sector or the system is under-resourced. Systems are fragmented. Families and kids report that they really have a hard time accessing service, and there are wait times for service. And then the larger question is, gosh, once they get the service, is it what they need? Is it actually what they need, or did we provide the service that they were hoping for? And then continuity of care is very problematic. Once you transfer geographically or transfer from children and youth to adult mental health services, the continuity of care can be problematic. The continuum of care is out of balance with fewer prevention initiatives versus mental health service provision. We're still looking at evidence-informed and evidence-based practice and what are the best practices to help kids and youth presenting. How do we disseminate this knowledge amongst the various children's mental health agencies and amongst the sector in general? We talked about the challenges of continuing education, and that the sectors are still fairly siloed: education, medical, and mental health. We're still not great at communicating between sectors, but this is one example of an exciting initiative where we're trying to bridge those gaps. And I can't end my section of the presentation without some reason for optimism. There is a large push in the sector to reduce stigma, to recognize the problem. The 10-year Ontario Mental Health Plan, moving on mental health, the ministries are working together and collaborating more. Some specific examples would be the provincial telepsychiatry expansion to reach more families and children and provide psychiatric assessment and treatment to the north. And then the Provincial Centre of Excellence for Child and Youth Mental Health.
So just a quick note, thank you, Greg. I've seen a couple of hands up for people who have questions. We just ask that you hold your questions to the last 10 or 15 minutes. I will put the question box on your screen so you'll be able to ask questions directly. So just a reminder, please hold your questions just for a little bit longer. Thank you. Okay, welcome, Roberta.
Thank you, Renee. And thank you, Greg, for a really good context setting around complex mental health issues and a good lead into to what's happening on the system transformation front. First of all, I'll just talk about where I'm from. I'm from Children's Mental Health Ontario, and I know we've got a wide range of people on this webinar, so some may be more familiar with us than others. We represent and support the providers of child and youth mental health, community-based mental health treatment services throughout Ontario, and our core membership is more than 85 accredited community-based children's mental health services centers that serve thousands of children and their families annually. Our mission is to champion the right of every child and youth in Ontario to mental health and well-being, and our vision being an Ontario where every child and youth grows up mentally healthy. We represent our members, we work closely with government, and we work across sectors to try and achieve a lot of things that I'll be talking about in terms of system transformation and a more cohesive and integrated children's mental health system in Ontario. So I'm here primarily to talk about the system transformation process that's underway, and I'm going to cover, main areas I'm going to cover are some context around system transformation. It's been touched on a little bit in the introduction by Renee and a bit by Greg. The goals, the elements of system transformation, and then the timing of this process that's now underway. I thought before going any further, it would be a good idea to get a bit of an idea of the degree of familiarity people have around the System Transformation Initiative. And you'll see we've got 4 categories: no knowledge, basic knowledge, working knowledge, fully informed, no knowledge. Oh, okay, well that's good. Then it's then I won't. Then I'll be saying some things that are new. Great. So basically, about half the people have no knowledge of system transformation. So I'm going to start off with some context that's already been referred to. But basically, we've had quite a process to get to where we are today. And the 10-year comprehensive mental health and addiction strategy that was released in 2011 really lays out a 10-year vision by the government for improving mental health and addictions programs and services across Ontario for children, youth, and adults. Then a further distillation of that came down in 2012, and that's called Moving on Mental Health. So this is taking the open minds, healthy minds, and focusing on reforming the system for children and youth. And we refer to this generally as the System Transformation Initiative. and this is led by the Ministry of Children and Youth Services, which does provide the funding for child and youth mental health services in Ontario. The objective, to transform the experience of children and youth with mental health problems and their families so that regardless of where they live in Ontario, they'll know what mental health services are available in their communities and how to access the mental health services and supports that will meet their need. This goes back to the type of things that Greg was talking about in his last couple of slides around the challenges that there are at many levels, both with youth, with families, with caregivers, family physicians, educators, in terms of the range of services that are available at the community level. What we find is that there are many people who don't realize that service and help is close at hand. And so with moving on mental health and system transformation, the hope is that there will be a greater degree of awareness through the initiatives that are going to be undertaken, and that everybody will know where they need to go to access service. And I'll get to how that'll happen in the next few slides. There's basically 5 elements of the Moving on Mental Health Action Plan, and those are creating and supporting pathways to care, and defining core services, establishing community lead agencies, and I'll talk about those in quite a bit more depth, and then creating a new funding model for the system, as well as building a legislative and regulatory framework. Pathways to care is essentially making it clear to children and youth, no matter where you are in the system, that there is a pathway to the appropriate level of care, and that can be at the beginning of that journey or as people are moving through and having different needs. For instance, a child who is referred from a school and may go to a community mental health center, and at that point there may be a determination that services could be provided there, that there may be a medical referral necessary. So basically, rather than people going in one door and not being sure where they're going or what the pathway is that they're clearly supported in moving through the system as required. Also, we want it to be clear that families should know what to expect when they approach the school or their primary care practitioner about a mental health problem rather. And I know of a case where somebody approached the school in a new community and talked about the challenges their son had at school the previous year and not going to school and social anxiety. And in that case, the school was very well connected with what was going on in the community and made those linkages and pathways. So that happens better in some places than others. But what we want to do is make sure that no matter who you are and where you are in the province, that it's clear that no door is the wrong door. And so that goes to the question then of transparency. So again, you shouldn't have to worry whether or not you're in the right place. You'll get help. Core services. This talks about, and this will make a little more sense, I guess, when I get into the lead agency slide. It's looking at what the core services that need to be in every community, region, and provincially for 0 to 18 years, reflecting the mix of service that's required in a community, and also recognizing the available resources and where there may need to be linkages outside of the immediate community. Setting up a system that ensures there's flexibility to meet changing needs, and also working on connecting the pathways between mental health needs as well as sectors dealing with child welfare, youth justice, and complex special needs. So the lead agencies are something that this is really the most visible part of system transformation at this point. So I'm going to talk to you about what the lead agencies are, what their role is, and how are they chosen. Lead agencies, unlike, say, a LIN, which with a purpose-created agency. Lead agencies are existing organizations in communities across Ontario who will be responsible for providing the provision of core services in their service delivery area and for collaborating with other sectors. So that includes hospitals, schools, youth justice, and child welfare to ensure a continuum of service. Lead agencies will be strong agencies with clear mandates and high visibility, the capacity to evaluate and report on outcomes and respond to emerging needs, take a leadership partnering role with others, including education and health, and will be able to assess community needs, identify gaps, outcomes and investments, and shifting resources. Lead agencies will be responsible through contracts with MCYS for core services within their communities. So at this point, there are approximately 440 direct contracts between the Ministry of Child and Youth Services and local children's mental health providers. Once the lead agencies are in place, and I'll get into the numbers of them, they are the agencies that will have the direct funding relationship with MCYS. The agencies who are under their responsibility in a particular geographic area will receive funding from the lead agency, not directly from MCYS when the transition is complete in 2 to 3 years. The lead agency area is a geographic unit for planning, but it's not a boundary to access. So when we get into looking at community mental health plans and where services are best accessed, just because somebody's in a certain part of the province that doesn't have a certain service in that community, but it may be found in the next service area, that's not a boundary, that's not any barrier to service. The lead agencies will be delivering the services through direct delivery or subcontracts. And so, as I mentioned earlier, community members will know who to go to and who's accountable for services in their communities. So the lead agency will, in addition to providing services that come under their area of expertise, will also be working with the local community to decide which of the which organizations are best suited to provide various other types of services. So a certain lead agency would perhaps there's another agency in the community that's best placed to provide counseling services or different types of interventions. So in November of 2013, the ministry announced the 34 service areas for Ontario, and these are geographic areas, as I mentioned, and they were basically decided by using census data. So there are service areas for large urban areas like Ottawa and Toronto. There's larger ones for the north, southeastern Ontario, southwestern Ontario, and the lead agencies are being implemented in a couple of different waves. The first round of lead agency selection happened in August of this year, and a call for a Toronto lead agency was issued just this month, and then the application for the remaining lead agencies will be happening next year. I should just go into a little more detail here. So now that the lead agencies are named, they will be responsible for determining through two major processes, what's called a core service delivery plan and then a community mental health plan for each of their areas of responsibility. With the core service delivery plan, they'll be working with all of the other agencies within their area to decide who's best placed to do and provide which service. And that core service delivery plan will need to be approved by MCYS before it's actually put into place. In terms of the community mental health plan, this is where lead agencies will be playing a convening role in the community, and they will be working with other sectors, so health, education, youth justice, and child welfare, to make sure that services are coordinated. And as Greg mentioned, some of this some of this is happening now. It's happening better in some areas of the province than others. But basically, the lead agency will be the one who knows where you should go to get the best kind of service or the most appropriate service. As you can imagine, I'm sure this is a first-time huge initiative for everybody involved, and there's still lots of details to be worked out. We're at the very early stages. So the first 14 lead agencies will be having their initial orientation session this month by MCYS, and that will be followed at during the same week by a learning institute that's being held by the Ontario Centre of Excellence for Child and Youth Mental Health. And under system transformation, the Centre of Excellence has a knowledge broker assigned for each of the service delivery areas in Ontario, and so they'll be working closely with them to help them figure out the core service delivery plan and the community mental health plan. Our vision is an integrated system where we have our community-based children's mental health services at the center, and the other sectors are all intersecting. So now, if we had another type of diagram, we might have some dotted lines, we wouldn't have the intersecting circles, but essentially our vision is that within the next 3 to 5 years, there will be a much greater level of integration and coordination among the various sectors. And when I say integration, I don't mean in terms of taking over each other's responsibilities, but understanding that if you are in a community-based children's mental health agency, the intersections that happen in your community with youth justice, with education, with health, so that people know where best children and youth can be served. I don't have a lot to say about funding model. I checked in with the ministry. The way the funding is handled will change somewhat. It will move to being, as I said, under the responsibility of the lead agency that will then subcontract to other agencies in the community. But what that's actually going to look like at this point isn't known. But they'll be looking at making sure that the funding envelope supports local communities as well as provincial and regional services. And the other piece is the legislative and regulatory framework. And again, I checked in with the ministry, but there's not really much to say publicly at this point about this part of system transformation, except to ensure that there will be strong accountability in place and that everybody's held to the same standard of care regardless of where they are in the province. The timing of system transformation, you won't see any changes on the ground for the next probably 2 to 3 years, because the first couple of years are really all about planning. So year one, that now starts with the initial 14 service delivery areas, we'll be looking at assessing the current state, starting to develop their initial core service delivery plan, and starting to make those connections for a community mental health plan. Year two, they'll begin implementing the plans, but none of the actual funding that's in place now in terms of the direct contracts that go from MCYS to individual community agencies will change until about year three, when they'll move to being under the responsibility of the lead agency. CMHO's role, most of the lead agencies so far, 12 of the 14 that have been named so far are Children's Mental Health Ontario member agencies. We'll continue to support all of our agencies, and we'll continue to work collaboratively with government to represent our members through the transformation process. We have a section up on our website around system transformation, and as I said, everybody who's involved in this is really working through a new way of doing things. So we want to make sure that we provide our members with the best information possible, and that when people have concerns about the transformation process, that they can share those with us and we can raise those with government. Our key interests are around some of the governance challenges that system transformation raises, because lead agencies will all have their boards of directors, as well as the agencies, the subcontracted agencies. So there's some questions around how the governance of lead agencies will be impacted when they have that greater responsibility and accountability for not only their own agency, but the subcontracted agencies under them. And right now, we are partnering with the Center of Excellence on a paper that starts to look at what some of those governance challenges may be, and we'll be discussing that paper at CMHA's conference that's happening in November. We're also, as you can imagine, with all the changes that are going on, we're concerned with change management, so we're talking to the ministry about how we may be able to work through some of those pieces and understand the challenges that both lead agencies and service delivery agencies will be facing in terms of just the logistics around this in the next couple of years. You can get more information on all of this. So a little plug for our annual CMHO conference that's happening next month in Toronto. We have the Minister of Children and Youth Services speaking at the conference, as well as the Deputy Minister and the Assistant Deputy Minister. So they'll be talking about what they're finding so far, still fairly early on in the transformation process, and what they're hearing from people, and how they intend to support the process as we move forward over the next couple of years. So that link will take you to our conference website. You can also look on our website at Children's Mental Health Ontario, and this is also a link to the ministry's website around moving on mental health. They also have an email sign-up, and so if you get that email alert whenever there's new information around lead agency processes and just news about the progress of system transformation, you can get that email alert, so that's quite handy. And yeah, that's it.
Thank you very much, Roberta. Thank you very much, Greg. We have about 15 minutes for questions and comments. I'm going to upload on your screen the question box, and I'll start to take questions as they come. I'll give you a couple minutes to ask them. Okay, so we've got a few questions to answer, and the first question would be, would you be able to provide a list of lead agencies?
Yes, and I will send that to you. And actually, there's a question about that, incorporating Indigenous communities. Yes, and I should have specifically mentioned that, because there is specific reference in Moving on Mental Health to Indigenous communities. And so that will be, depending on the service delivery area, working with the Indigenous community will be an integral part of the community mental health plan, as well as the core service provision. And then there's also specific reference to Francophone communities as well. So basically the idea is that each service delivery area has, Ontario, as we all know, is a very diverse province. So depending on what the makeup is in each geographic service delivery area, there will be a special attention paid to the specific concerns in that community and working with the appropriate local partners. Yes, we can definitely provide a list of the lead agencies. We can provide a list of the ones that have been announced so far, and we can also provide a list of all of the service delivery areas, so you'll know where the process is happening next.
Is that all on the CMHA website?
CMHO,
yeah.
and on the government site, but we can provide a direct link as well.
We also have a series of questions from people about how to get access to the slides and the webinar. So just a reminder, after the webinar is completed, so tomorrow, you will be able to access the presentation on the complexneeds.ca website. Okay, other questions. Will the lead agencies be specifically equipped to treat children, adolescents with autism and comorbid mental health challenges?
So in terms of the lead agency, my understanding is that the lead agencies are children's mental health agencies, and that they're going to be responsible for coordinating the core service delivery, of which autism and other mental health disorders or mental health diagnoses are definitely going to be supported with the lead agency's involvement.
Yeah.
I hope that's specific.
That is, and so the lead agency is responsible for making sure that all of the services that are currently available through the children's mental health system continue to be provided, but they won't necessarily be delivering on a specific service if it's more appropriately delivered by another partner in the community. There's no intention that the lead agencies are the only ones providing services. They're really they're an administrative hub who will continue to provide services as they're best placed to, as they are now, but then recognizing that other agencies in the community may be more specifically equipped to handle, for example, the ones mentioned here, autism and the comorbid mental health challenges.
Okay, great. There's also a question about the stats and whether or not they include First Nation communities. I guess either Greg or Roberta can answer that.
I think that the statistics are likely they do not include certain communities. It would be more of a urban sample. So unfortunately, I'm not sure that they include all populations or represent all populations. I'm sorry about that.
A question, hello, I'm not sure who might be best positioned to answer this question. Both guest panelists could speak to it, I think. The earlier part looks like this question might not actually be finished. So whoever, oh, here we go. In the earlier parts of the webinar, you mentioned that youth includes people up to the age of 29. For youth who are over the age of 18, what sorts of agencies and supports are available, especially for those people who do not have enough funds or private insurance to pay for counseling or therapy or medication? It seems like the transition into age of majority leads to a lot of discontinuity.
It's such a good point. When we're talking about transition, there's a difference between transition and transfer of care. So once a kid or youth turns 18, they have to transition from MCYS-funded agencies and services to typically health services, OHIP-funded services. And there's a difference between making a transition, which is sort of administrative, and then a transfer where there's a direct handoff from one care provider to the other, making it a smooth transfer of information and care. And I think that we're probably okay at making transitions, but we're probably not great at making transfers of care. For youth that are over the age of 18, the publicly funded agencies or hospitals or clinics would be through health, OHIP-funded clinics, hospital-based services, community-based services as well. So I think that there are definitely services out there for kids in that transitional age, but they are harder to access. And again, it's a bit of a fragmented system and a little bit of a duplication of service.
And I would just add to that that's definitely an issue that is receiving a lot of attention, and it's one of the things that has been listed as a priority in moving forward through the next steps of the 10-year strategy on mental health. The first 3 years in moving on mental health were really focused on children and youth, and in this year's budget, the government announced that there was really going to be a focus on the whole transition piece because, as Greg said, and I think people are well aware, it's hugely problematic.
So thanks for the question. It's a really great question, and it gives us an opportunity to have a nice discussion about it.
These are really good questions. I hope people keep them coming in. Just as a reminder for people who are raising their hands, there's a box on your screen that you can actually type in the question so you don't have to raise your hand. So if you type in the question, we'll get to you through the list. We'll get through the list. Thanks. Other questions. Are the service areas aligned with the LHIN catchments?
I would say there's not specifically, but I would say they would be within the range. They weren't set up in the same way as LHINs, and there's an expectation that lead agencies will work with LHINs, so I would say in some areas that may cross over more than one LHIN boundary.
Okay, and I think there's some questions, some technical questions. The webinar is still on for people who are not able to see the screen. Go back to the email address we gave you at the beginning, and Meredith is here to help you work that out. Where's
waiting? On waiting.
So it looks like there's a question on waiting lists. Are there waiting lists, and if so, how are they handled? I think that waiting lists for services in different agencies are definitely a challenge, and my sense is that one of the positives that will come out from the lead agency structure and the transformation is that the lead agency over the next 3 years will meet with their partner agencies to get a sense of what service do you provide, what core service do you provide, how many people are providing that service, and then once the family actually calls in to a centralized agency, centralized intake like the lead agency will be best able to direct the family to the agency in their area with the most direct service, and hopefully this will lead to fewer wait lists and less time spending on a wait list because the service will be coordinated and the lead agency will have a sense of, gosh, of the agencies in our area, who has the shortest wait list, who can pick up the case immediately, what service is best for the family. So we're hoping that the wait times will decrease as a result of the system transformation. I'm not sure if that's fair to say.
Yeah. I mean, definitely the expectation is that with greater coordination and collaboration and integration of service that will impact wait lists. But we recognize that continues to be a challenge. But if there's a greater awareness of where sometimes people should go, maybe initially, as opposed to at this point perhaps seeing one person and then being told that they should be going to another agency, that all impacts wait lists. So the idea is to make things streamlined so people will get the help where they need it, when they need it.
Okay. And another question on what linkages will the Children and Youth Health Services have with upcoming Child Mental Health Survey to be rolled out in January?
I don't know what the survey is. Who is this survey through? I'm not.
So Fatima, if you're still there, if you just want to type in a bit more information for us,
Yeah.
that would be helpful. And in the meantime, I'm just going to check to see if they're...
Through McMaster and Statistics Canada. Thank you very much. I'm going to look into that. And we'll let you know.
So Fatima, if you want the answer, why don't you send an email to the contact address on complexmentalhealthneeds.ca, and we'll connect you with the answer. Other questions. With lead agencies identified, is there an agency identified to help expedite process for diagnosing FAS, FASD, as this process waiting list is over a year? To be diagnosed, to have psychiatric evaluation and IEP in place to help a child progress in education, which would help lessen behavior or other mental health issues.
So my understanding is that the lead agency identified would not necessarily have in their service area an agency identified only with dealing with FAS or FASD, but the lead agency would definitely have a catalog of services of their partner agencies, and then they would be able to direct the family to the most appropriate agency in their service area.
Yeah, the objective is that we use the line, every door is the right door. So as Greg said, if somebody comes into the lead agency, they would know exactly who to connect them with in the community if it wasn't a service that they provided, and they would facilitate that connection as well.
So the lead agency would know in their service area, this agency has some expertise in FAS, FASD, and diagnosing, and they might have a clinic, but I don't think a specific agency would be created for these more complex or specific categories. Is that fair to say?
Yeah, that's fair to say, because if a specific service wasn't available in that service area, they would then connect the family with a place where they could access that service. So yeah, there won't be a creation of new services, because there's a lot of one of the goals is to reduce a lot of the duplication that happens now.
Okay. This question is for Greg. It's a follow-up question to an earlier question. This person says, my earlier question about children and autism was not written clearly. I work with children and youth with autism who often present with anxiety, depression, etc. We find that mental health services for this population are limited due to a lack of specialization of providers in mental health. Does part of this transformation process address gaps such as this in the current range of providers?
So if I'm understanding the question correctly, it looks like the question is about children and youth with autism, and they have other presenting issues, and that mental health agencies in your area either don't have the service, or they're not, they don't have that as their main focus. I think part of the transformation is really, again, to sort of come back to the main point, it's establishing the lead agency who would then take a catalog of services provided in their area, and if a gap was identified, like, gosh, there are not many people in our area who work with kids with autism, well, then we need to provide training, or we need to divert maybe some resources towards our community partners, because that's a gap in our service area.
Mm-hmm. Yeah, definitely.
So I think it's a great question, and definitely that is something that is going to be addressed over time by the lead agency, but as you indicated, it may take 2 to 3 years for that to roll out on the front line.
And this, when I talked about the development of a community mental health plan, this is an excellent example. So the lead agency will be responsible for convening not only agencies that fall within the child and youth mental health services, but also education, health, youth justice, child welfare, and bringing them together at a community table so that they can identify what the range of services that are currently available, where the gaps are, how they might be addressed. So to really try and coordinate service and ideally over time make things seamless.
And I think it's such a great question because presumably, I mean, our guess is that all of the service areas, all of the 34 identified service areas are going to have similar gaps. Gosh, most of them are going to have gaps in the areas of transitional aged youth or specialized services for kids with FAS or autism. And that provides a greater opportunity to have a coordinated education or training plan because you're now only dealing with 34 service areas and lead agencies as opposed to trying to coordinate a training for 400 some agencies across the province. I think it's a real opportunity. I don't know if you would agree as well.
Mm-hmm. Yeah.
Okay. So we can take a few more questions. This question is asking, not sure who's the best person to answer, but I just thought I would ask, to the best of your knowledge, will there be any further initiatives at the school level to provide increased supports in school for children who have complex mental health needs and are mainstreamed, so not in a specialized program, so that they do not need to seek or rely solely on outside assistance? Currently, social work or behavioral supports are short-term, consultative, 6 sessions max, and do not follow or check in with the child consistently. I don't know if you can answer that or if there are any thoughts on that.
I mean, these are such good questions. I mean, it really speaks to the sophistication of the audience whom we're talking with today. I'm not sure that I have any specific answers, but again, I think that the lead agency would be responsible for engaging the other sectors, education and health, and gosh, what's the education system need? How can the children's mental health system support kids who are struggling in the school system?
Yeah, I guess just what I would add to that is there was a certain investment in the education system during the first 3 years of the mental health strategy and with increased child and youth workers in school and the appointment of mental health leads. But of course, again, that your question speaks to the fact that there's obviously still many needs out there. And again, this goes to developing the community mental health plan, bringing all the partners together and figuring out where the gaps are, and with the questions that you raise, determining if there's a greater collaboration that can happen, because there may be some instances where the school is not well connected with what's happening within the community, and there may be instances where if that happened, that would address some of the needs in the education system. So these are the sort of things that we definitely expect to see coming up at the community mental health planning tables. And again, they're important issues to keep raising based on what people's experience has been with the investment over the last 2 to 3 years, and where it's helped and where there's still gaps. So I appreciate that perspective on what that investment has done or hasn't done so far.
I mean, I could just give one quick example of MCYS funded initiative, which was the school-focused or school-targeted initiative, where MCYS funded social workers who are attached to a children's mental health agencies, but they receive the referral directly from the school board. So it's been a really nice collaboration between the school boards who get to refer kids that they think are at risk or at need directly to children's mental health and sort of bypass the intake and difficulties connecting with our service. So it's been really a great collaboration. So that's one example.
And we have time for one more. So this last question is, what about addressing issues surrounding LGBTQ and youth? Is this included as part of addressing complex mental health issues in the plan of action discussed? I'm not clear if this person is asking if this is included in the training or if this is included in some of the pieces that the presenters discussed.
Let's see. Maybe the person writing the question could just clarify quickly the second.
Okay.
Sorry, what was this one?
Oh, let me go back up. So what about addressing issues surrounding LGBTQ and youth? Is this included as part of addressing complex mental health issues in the plan of action discussed?
Well, I think much like other questions, I think that all aspects of mental health are going to be addressed and coordinated with the lead agency. And I think that the lead agency we think of as the administrative hub, but the other function of the lead agency, as we've mentioned before, is really to meet with their partner agencies in their service area and get to know what service they provide, what are they good at, what do they currently offer, and any gaps such as issues surrounding LGBTQ youth would definitely be addressed by the service, by the lead agency. They would be responsible for either identifying a local agency or providing training for agencies in their service area to meet that need.
And I'd just like to take that last question.
Okay, we'll take this last question, which the person is asking, is there any help? Oh,
sorry, was about the lead the funding question.
You want to read it?
Yeah, sorry, just scrolling down here. Yeah, I just wanted to respond to that because that's obviously an excellent question that will continue to raise itself. We recognize that that there continue to be shortage and fragmenting of services, and that there's a need for an increase in core funding. It's something that we at CMHO continue to discuss and advocate for with the provincial government, and so that will continue.
Okay. So I think those are all the questions that we can take for now. Really appreciate all the really solid questions that came through today, and really wanted to thank our presenters, both Greg and Roberta, for being here and sharing such fantastic information with us. Thank you very much. And a reminder that next Wednesday and next Thursday, so October 8th and 9th, are the first face-to-face trainings that will happen in Thunder Bay. And then the following week, we'll start with our second webinar on health equity. So all of this information you can find on the website, www.complexneeds.ca. Thanks very much, and we'll see you in a couple of weeks.